All right. Well, hi, everyone. Good morning. My name is Katie, and I'm here with Dr. Eze and Dr. Fresh, as well as our fantastic speaker, Dr. Hull, this morning. I'm very excited to start the next session for Peds Picks for Practice this morning. So we're very excited to be joined by Dr. Nathan Hull. He's an associate professor of Peds and Emergency Radiology at Mayo Clinic, and he'll be presenting today on bowel obstructions in children. Just to run through some kind of reminders of these sessions. Material in the lectures is for educational use only and the property of the presenter. So any PDFs of slides or lecture recordings that we send out afterwards, feel free to reference them, but should not be shared. Of course, though, if others are interested in the content of these lectures, please encourage them to sign up. And very excited to have everyone with us today. One other kind of reminder, I'll put this in the chat, but if you haven't already, if you could register at the following link, that would be fantastic. Usually it takes about 3 to 5 minutes, and just to make sure that we're tracking your attendance for today if you're interested in getting a certificate. All right. And so I think if there's anything else, Dr. Eze or Dr. Fresh you wanted to mention, I might turn it over to Dr. Hull to start the presentation.
Great, thanks, Katie. Let me see if I can bring up my slides here. All looking okay, Katie?
Yes, we can see your slides there.
Fantastic. Okay. Well, good morning, everyone. I'm excited to be with you virtually. Wish I could be with you in person, but I'm excited to chat today, and hopefully we can learn something together. As I said, my name is Nathan Hull, and I do pediatric and emergency radiology at Mayo Clinic in Rochester, Minnesota, and was lucky enough to train under Dr. Don Fresh at Duke a handful of years ago. So I'm really excited to be part of this. Today we're going to cover some topics on neonatal and pediatric bowel obstructions, and I have no disclosures. And for any of you who want some good reference articles about pediatric bowel obstructions, here's the title and the QR codes if you want to scan them, and I'll try and make these available after the talk if you'd like those. So our learning objectives are going to be discuss a practical approach to how to look at pediatric bowel obstructions using an evidence-based algorithm, review imaging spectrum of pediatric bowel obstructions and their underlying causes, connect imaging findings to management, and then hopefully have fun and learn something. And the way that I set this talk up is I'll do a little bit of didactics with the kind of algorithm approach and the pattern-based approach, but then a lot of the cases are going to be shown as unknowns. And I'll ask you to think about it. If you would like, you can put your answers in the chat just to kind of see how you do. Again, this isn't graded or anything, but just hopefully this can be kind of interactive and a fun session for you to learn something. So pediatric bowel obstructions are one of the most common surgical emergencies in children, and imaging really is has a valuable role in diagnosing and localizing these obstructions. Oftentimes, radiographs are the best first imaging modality. They're the most available. They're quick, easy, relatively inexpensive, and you can look for signs of obstruction. You can try and localize the obstruction, whether it's an upper tract or a lower tract. You can look for signs of perforation. We'll go through all of these things. So first off, what are radiographic signs of obstruction? So if you get a radiograph, what are the things that you are looking for? So dilated loops, stacked loops of bowel. If you have an upright or decubitus, you may be looking for air fluid levels, and I'll show you what that means, or paucity or lack of bowel gas in certain areas of the abdomen. So if you just take a look at, these 4 images, you can see you have a really dilated stomach that's gas filled and a little bit of distal bowel gas, but not a lot. And so you might be thinking this is an upper tract obstruction, maybe a gastric outlet obstruction because of the massive dilation of the stomach. And on this film, you see there are multiple kind of slightly distended but stacked bowel loops kind of going side to side. And so you might think, there's no bowel gas down here in the rectum. If the child's not stooling or having, abdominal distension, you might think maybe they have a lower tract obstruction, something down in the colon. Here's an upright film where you see these air fluid levels, where you can see the contrast between air and fluid in a bowel loop. and that's a sign of stasis, and you can see that in obstruction. You can also see it in postoperative ileus. So it's not a specific finding, but it certainly should cue you in that there's some stasis in bowel and maybe there's an obstruction. And then again, here's another example where you have a dilated kind of stacked loops of bowel. There's no real bowel gas in the right upper quadrant or down here in the pelvis, maybe just a little bit. You'll see this case a little bit later. So first, let's just cover there's different imaging modalities to work up bowel obstruction. So fluoroscopy means when we do live x-ray, and sometimes that involves giving contrast to the pediatric patients. And we usually use this in neonates and very young children. And I'll show you kind of how we use this. But one of the primary things that we use it is for an upper GI, and that's where we give contrast under live x-ray and we look for midgut volvulus, which is a surgical emergency. Or we do an enema exam where we're kind of looking to see if there's a colonic obstruction. Ultrasound, this is great because it doesn't use radiation, has pretty good resolution. You can see things in real time. It's relatively inexpensive. No sedation is usually needed, and you can kind of just target the evaluation rather than doing the entire abdomen. CT and MR are going to be generally harder to come by as far as availability, and they're more expensive. CT uses radiation, but it does help you localize obstruction, may help you identify the cause, and also provide a surgical roadmap as to what needs to be done. MR is not used very often in the workup of pediatric bowel obstructions, but occasionally it might be, and I'll mention a few instances here in the talk. So first off, I know you already had a talk about neonatal bowel obstruction, so it's not just going to be about that, but hopefully this will be a nice review. So first we're going to talk about neonatal bowel obstructions, and I just provided this table for you as kind of a nice way to look at it. So I like to break this up into high or upper tract obstructions and lower tract obstructions. So you can see here's kind of the list of things that can cause an obstruction in the upper tract, and here's in the lower tract, and we're going to kind of talk through all of these. So here's kind of that algorithm that I mentioned. So if you have a neonate that you suspect may have a bowel obstruction, usually the first thing to do after a physical exam would be an abdominal radiograph. And from the radiograph, there are certain diagnoses that you can make just from the radiograph. And so those include esophageal atresia, duodenal atresia, and perforation, which would obviously be a complication of obstruction. And those, generally go straight to surgery. Otherwise, if you see different areas of distended bowel loops, you can break it up into an upper or lower tract obstruction. So here again, upper tract obstruction, usually in neonates, we're going to, if after the radiograph, if we need to localize, usually fluoroscopy or live x-ray in an upper GI study. If it's a lower tract obstruction that we suspect, generally we're going to move on to a fluoroscopic enema. So first, let's focus kind of on this area where we get an abdominal radiograph and what are the diagnoses that we can kind of make from the radiograph itself. So here's our first unknown case. What is the most likely diagnosis? So I'll give you a minute to kind of just look at this exam, kind of see what you think. If you are inclined, you can put your answer in the chat to kind of see how you do and how everyone else does. Yes, or if you feel comfortable, you're welcome to unmute and tell me what you think too. So just kind of go through these findings as you're thinking about this. So
we have an answer C.
Great. So see, great. Great. I see some of you put in some answers in the chat. That's great. So you're right. The answer is esophageal atresia. And some of the clues that you would see with that is they put in an oral gastric tube and it's just kind of stuck right here at the level of the clavicles. It isn't going any further. So that's a good sign that there may be an esophageal atresia if you can advance. the enteric tube. Also notice there's no bowel gas in this baby. And usually, even right after birth, there's at least a little gas in the stomach. It may not have worked all the way through the bowel on the, right after they're born, but there's no bowel gas. And so you see this and the no bowel gas, you should think maybe this kid might have an esophageal atresia. So very good. So as you may know, there are several different types of this, uh, where there is a blind atresia and there's no fistula. So that's this type, and that might be kind of what we were dealing with on that last case. There can be a proximal atresia with proximal fistula, and in this case, you wouldn't have any bowel gas either because there's no connection between the airway and the bowel, or the upper esophagus to the lower esophagus. So that radiograph we just saw was probably one of these two flavors. And then there are also several other types where you have an atresia with a distal fistula. This one would have bowel gas, as well as this one, where you have two types of fistula, or kind of the so-called H type, where you just have this kind of bridge where there's no atresia, but there's just a fistula between them. So here's the next question. If an esophageal atresia is suspected, what other abnormalities may be present? What else should you think about? What do they need to be screened for? And I realize this is a alphabet soup, lots of abbreviations here. So this is neurofibromatosis 1 and neurofibromatosis 2. This is Facey's syndrome, which stands for a bunch of stuff. Good, good. So see some answers for D, and that's the correct answer. So a Bacterol syndrome. So as you can see in this case, there's kind of a big dilated air-filled esophageal pouch. And there is some distal bowel gas, so you know that there's probably a fistula, but you notice there's a hemivertebral body down here in the lower thoracic spine, kind of goes together with, an esophageal atresia with a vertebral anomaly. You should be thinking about Bacterol, which includes vertebral anomalies, anorectal malformations, cardiac problems, tracheoesophageal fistula, renal anomalies, and limb defects. So great job. Those are all these associations that when you see signs of atresia or tracheoesophageal fistula, you should think about Bacterol and maybe do some appropriate workup to look at their heart and their kidneys. So just some teaching points. If there's a failure of passage of the enteric tube into the esophagus, that should make you worried that there's an atresia. Look for associated abnormalities. And generally, the repair of these children, at least kind of in my practice, usually occurs in the first couple of days of life, assuming that they're big enough for surgery. We usually don't do an esophagram for diagnosis because they're pretty high risk for aspiration. But sometimes after surgery, we'll give some contrast and use fluoroscopy to make sure there's not a tight stenosis or there's not a recurrent fistula where they did the repair. Okay, so we're going to move on to our next case. Let's say, what is the most likely diagnosis in this case? So you see there's kind of a dilated air-filled stomach. And then right here is the distal stomach. And then you see this dilated kind of air-filled bowel loop and then nothing else. So very good. I know some of you are answering in the chat. That's great. So this is a case of duodenal atresia. This is one that you can kind of see on the radiograph and kind of know what's going on. This is the so-called double bubble, where you see the bubble of the stomach and the bubble of the proximal duodenum that are dilated and no distal bowel gas. So that's kind of the distinguisher, as you see the double bubble and no distal bowel gas. It's most common upper obstruction in neonates. And this is the association you should really remember is, there's a high percentage of these children that also have trisomy 21. And so you may also need some additional screening with their heart and other abnormalities that can be associated with that. So here's just a companion case. This is a case of jejunal atresia. And this is the so-called triple bubble, where you have the stomach, here's the duodenum, and then here's the jejunum. And then we really had no distal bowel gas on this child. And if you do have this, you may not always see this on an X-ray, but if you do, you should be thinking about an atresia or some sort of congenital stenosis. And other abnormalities can exist with this condition, including gastroschisis, meconium ileus, and we're going to talk about some of these things, malrotation. And they may or may not have a microcolon, meaning their colon is really, really small if you did an enema. And we'll cover that here in a little bit in the talk. So here's our next case. Got a neonate with a distended abdomen. What is the most likely diagnosis? So this one's maybe a little bit trickier. You can see there's kind of bowel loops going side to side, all the way kind of down. Don't necessarily see hugely dilated loops, maybe a little distended. So you might think maybe they have a lower tract obstruction since this is an obstruction talk. But there are some key findings that I would just point your eye to. So there is some bowel wall thickening right here of this bowel loop. And notice on this bowel loop and this bowel loop, see how you can see the bowel wall. You can see both sides of the bowel wall. And this is a case of pneumoperitoneum where this child has already perforated from a bowel obstruction or necrotizing enterocolitis. So this is the so-called, it's called Wriggler's sign. And so normally, you can only see the inside portion of the bowel wall. That's because there's air in the bowel wall, or sorry, air in bowel lumen, which contrasts with the soft tissue contrast of the bowel wall. But you don't usually see the outside or serosal surface. That's because it's usually up against other soft tissue structures. But if you see both sides of the bowel wall, such as in this case, all along kind of these two bowel loops, that should make you think maybe there is free air or pneumoperitoneum and the child is perforated. And that can be one of the signs. And keep in mind, usually when we take these x-rays on neonates, they're laying totally flat or supine. So free air can be hard to detect. You may not always see it up here underneath the diaphragm like you're used to seeing it in older patients when they're upright. So again, here's those findings. And then to increase your sensitivity, if you wanted to confirm that finding, you could do a lateral decubitus film. And here you see all this air over the liver. And there's also little triangles of gas here in between distended bowel loops, confirming that this had perforated and this child had some necrotic ileum that needed to be resected. So x-rays can be really good at detecting this, but without the decubitus, your sensitivity is only moderate. So here is a supine case where they don't really have distended bowel loops, but you see this lucency. It kind of projects over the upper abdomen, and then you see this line outlined. That's the falciform ligament, sometimes called the football sign. And what I always try and remember is I kind of start my eyes down here and run my eyes kind of up towards the spine. And if there's ever a change in density right here, right, then if it gets more lucent or light, you might think there's free air in the abdomen. Because the liver should be kind of uniform density. If you go back to this case, see how the liver is kind of uniform in density, whereas this one, there's this line that changes in density. So, and again, the upright, if you do an upright film, your sensitivity of detecting free air goes up to about 85%. If you do a left lateral decubitus, your sensitivity goes up to 96%. So it's much, much easier to see in a decubitus film. So if you're ever suspicious that a child is perforated, always get an upright or a decubitus film because that's going to increase your sensitivity to detect perforation much better. Other signs of free air. So again, a change in density kind of over the liver, as you can see in this case. If you can ever see the diaphragm go across the spine, that's always a sign that there's air somewhere where it shouldn't. So that means there's either air underneath the diaphragm or there's air in the mediastinum. Like in this case, this is called the continuous diaphragm sign. So both of these are signs of, air where it shouldn't be, either in the peritoneum or in the mediastinum, excuse me. Okay, so we kind of covered this part right here. So now we're going to move on to kind of upper tract obstructions, okay, or if you see bilious emesis. And then so upper tract versus lower tract obstruction, if you get a radiograph and there are 3 to 4 dilated bowel loops or less, then we usually kind of put it in the category of an upper tract obstruction. If there are greater than 4 dilated loops of bowel, or it kind of goes all the way down here, then you'd think lower tract obstruction. So that's why a radiograph is a great first place to start. You can kind of try and characterize, do I think this is an upper tract or a lower tract obstruction? So, and like I mentioned before, fluoroscopy or that live x-ray and upper GI series is generally what we're going to do in neonates. So here's a case where I've shown you this radiograph before where you got massive air dilation of the stomach. So how I like to break it down is when we do these fluoroscopic exams, there's basically kind of these 5 patterns that we're looking for. And there's normal, there's malrotation, there's malrotation with midgut volvulus with this classic corkscrew appearance. There's a complete obstruction and partial obstruction with a normal duodenal jejunal junction. So just show you a normal case. So when we do these exams, we have to show a few things. We want this to come across the midline, the duodenum to come across the midline and come back up to the level of the duodenal bulb. So here's some examples from a normal. We've given contrast. This is a lateral projection. So here's the spine, there's the stomach, there's the pylorus, and here's the duodenum coming retroperitoneal. Okay, so we want to see it come all the way back by the spine and have a retroperitoneal course. And about this time, we're going to roll the patient back onto their back. So here's a frontal projection. And we want to see the duodenum cross the midline and come back up to the level of the duodenal bulb. This is where the ligament of Treitz is, that's kind of holding the duodenum as it comes through the mesentery and becomes intraperitoneal. And then here's where we roll them onto their left, and you can see all 4 portions are retroperitoneal posterior before it goes into the jejunum. So that's kind of the normal pattern that we're looking for when we do this. So now let's look at some abnormal cases. We have a 7-month-old with abdominal pain and bilious emesis, so kind of yellow vomit, yellow or green. What is the most appropriate next step? So we do have, it's kind of a non-specific bowel gas pattern. It's a little odd that there's no bowel gas right here in the central abdomen, but the rest of it doesn't look too dilated. What do we do about this? So we could do watchful waiting, because they don't necessarily look like they're obstructed. If you have access to a CT, I guess you could, but this is a pretty young child for that. You could place in an enteric tube and repeat radiographs. That might decompress things. Or you could do a fluoroscopic upper GI exam if that's available. And I guess in our practice, anytime that there's bilious emesis in a neonate or a newborn, kind of less than a year of age, we're really concerned about midgut volvulus. So that's what we would have to rule out. And a radiograph cannot exclude it. So even though it doesn't necessarily look bad on the radiograph, we would still want to exclude midgut volvulus. So that would be kind of the correct answer in this case. So we do an upper GI, and these are the images that you see. What is the most appropriate next step? So let me just kind of describe the findings here for you. So this is a lateral projection. Here's the spine. Here's the stomach, pylorus, and duodenum, or duodenal bulb. And as the contrast comes back, you see it kind of comes and then just kind of does this kind of corkscrew appearance down. And if you look at it on the frontal projection, it comes kind of to the midline and then just goes over to the right. You don't never see it cross over to the left. So if you see these findings, if you did an exam or you sent it to a radiologist and this is what they sent you, what would you do next? So the correct answer should be emergent surgery. This is malrotation with midgut volvulus, and this is kind of the classic corkscrew appearance. So kind of what you're seeing is in midgut or malrotation, normally your bowel kind of during fetal development, your bowel herniates out of your abdomen, rotates 270 degrees, and then comes back in and has a fixed mesenteric attachment where you have the ligament of Treitz in the left upper quadrant and your cecum in the right lower quadrant, and there's this broad mesenteric attachment. But in malrotation, you have this narrow mesenteric attachment where your small bowel can kind of rotate and twist around its axis and can pinch off the vasculature, so the superior mesenteric artery and vein. And so basically you're infarcting your small bowel when you have a midgut volvulus when it's kind of torsed like this. And sometimes this is the appearance that we see on a fluoroscopic exam. And so that requires emergent surgery because otherwise all the small bowel will die. So some teaching points from this case is, we talked about the normal course of the duodenum. It should be retroperitoneal, cross the midline, and the duodenal jejunal junction or ligament of Treitz should be near the level of the duodenal bulb on the left side. Malrotation predisposes to midgut volvulus, which is a surgical emergency. And radiographs are not sensitive. So even if you have a normal or an abnormal radiograph, if there's bilious emesis, baby's really fussy, this is something that you should exclude. And traditionally, we've excluded this with a fluoroscopic upper GI exam, like I showed you. But there are several centers throughout Europe and in the United States that use ultrasound to screen for this, and they're looking for kind of this swirling of the SMA and SMB where those vessels are kind of twisting around each other. Okay, let's move on to the next case. This is a newborn female presents with vomiting or emesis. Which of the following should not be on the differential diagnosis based on the radiograph? She's got a neonate with some umbilical lines, got a big distended stomach, probably another big distended duodenum, so you kind of have a double bubble sign, but there is some distal bowel gas. So we shouldn't say duodenal atresia because there's distal bowel gas, but you do have a double bubble sign. So hopefully that cues you in that this is an upper tract obstruction, right? So,
E will.
sorry, what was that?
I'm saying E should
Yeah,
be.
yeah, E should probably not be on the differential for this radiograph. That's very good because all of these A through D are all upper tract obstructions, where E is a lower tract obstruction. Very good. So let's kind of look at this. So you can have duodenal stenosis, and this is kind of a congenital narrowing, but it's not totally atretic. There's an upper GI exam where we put contrast in and it just kind of stops. You can also see this with midgut volvulus. So either way, whatever, if you see contrast that just stops, that means this is a surgical case that needs to be explored and figure out what is causing that obstruction. Other causes can be an annular pancreas. So that's where the pancreas actually kind of has tissue that wraps 360 degrees around the duodenum and causes a stenosis. Here's a double bubble with distal bowel gas. This is a case that one of my colleagues did. I've never seen anything quite like it. See that double bubble? They put contrast in, and as contrast started to go through the really narrow duodenum, contrast actually started to reflux up the biliary tree because that was the path of least resistance because the duodenum was so tight initially. So if you look at his end images, he basically did a small bowel follow through with a cholangiogram. You can see it reflexing up into the gallbladder and into the biliary tree. Never seen anything quite like it, but this child went to surgery and had an annular pancreas. So that's one of the things on the differential. And then another cause of upper tract obstruction, double bubble distal bowel gas is a duodenal web. And so this is a fluoroscopic case where you can see that. And so really this lucency right here is a web of tissue that didn't resorb during development. So kind of there's just a cartoon version. And if you put your endoscope down and we're looking at this is kind of what you see. You just see a web of tissue with maybe a little slit where some contrast can get through, but really this web is kind of prohibiting it from going through. And this is sometimes called the windsock sign. In textbooks, you may hear that term tossed around. So remember, if you have an upper tract obstruction with duodenal narrowing, usually you have kind of a distended stomach, maybe proximal duodenum, but distal bowel gas. And your differential should include annular pancreas, stricture, web. You can even have crossing extrinsic structures or Ladd's bands. And if it just completely obstructs, even if you don't see that corkscrew appearance that I showed you on the last case, you should think about midgut volvulus. It should go to surgery. Okay, so this question, I'm going to skip a little bit just because I think it's a little tough, but which of the following is the least common cause of upper intestinal obstruction? And I gave you a whole long list, but congenital pyloric atresia is very rare. I'm just going to show you a quick case of this just so that you've seen one. Very rare, less than 1% of all upper tract atresias, but can be associated with other abnormalities at birth. So you can see there's just a single bubble on this radiograph, no distal bowel gas. They asked us to do an upper GI exam. This is when I was at Duke with Dr. Frush, and we put contrast in, and it didn't go anywhere. You can just see the stomach just kind of ends. There wasn't really an antrum or a pylorus. It just stopped, and this child went to surgery and was found to have pyloric atresia. So not very common, but it does exist. Probably more common that we see in babies is hypertrophic pyloric stenosis. So again, on radiograph, oftentimes you see a big dilated stomach, maybe a little bit of distal bowel gas. This is an upright view of the same child where you see big dilated stomach, air fluid levels. And where we practice it, we usually use ultrasound to kind of confirm that diagnosis. We're looking for a lengthened antral pyloric channel. So normally the pylorus is just this little short channel right here, but it becomes lengthened as the muscle of the pylorus and the distal antrum become thickened kind of in a retrograde fashion. So we look for a thickness, a single wall thickness greater than 3 millimeters, and we look for this channel length to be greater than 15 millimeters. So here's the duodenal bulb. It's usually kind of triangular, spade shaped. The normal pyloric channel should be right here. You can see its length and all the way out like this as it's measured here on this lower image. And then you can see the single wall thickness. The hypoechoic or dark structure is the muscularis layer. So you can see the muscle is thickened, measures about 5 millimeters. This is a case of pyloric stenosis. This sometimes can be diagnosed on a fluoroscopy. So you can see big dilated stomach kind of coming down to a little narrow channel. Here's where we turn them kind of an oblique lateral. And you can see there's just a little tiny contrast sneaking through. This is the duodenal bulb. So this is sometimes called the string or ribbon sign as it sneaks through, and then the mushroom sign of the duodenal bulb kind of as it caps over this thickened muscle. And this is usually treated with myotomy.
I was going to briefly unmute. Dr. Rice has a question in the chat.
Yeah, go ahead, Dr. Rice.
Looks like he's
Hey,
asking.
Nate, it's Henry Rice here. It's good to see you, man.
Hey, great to hear from you.
For those who don't know, I'm one of the pediatric surgeons from Duke, and I thank you all for contributing to this really valuable lecture series. Can I ask the folks online? I don't know exactly who you are, I'm sorry, or where you practice, but how many people have access and use ultrasound for babies with potential pyloric stenosis? And how do you use it, if you do use it?
Yeah, great. I'd love to know.
If you don't mind me asking, Nate.
No, of course. That's great.
Anybody? Don't be shy.
Hi, I'll volunteer. My name is Stella. I'm a pediatric surgeon from Kampala, Uganda at Mulago Hospital. And we do have ultrasound scan available, usually based on the age of the child. And then the presenting symptoms, the clinical picture will suspect pyloric stenosis. And then ultrasound scan is the first test that we will request for. It's only in cases where maybe it's like equivocal findings and measurements just don't seem to fit the clinical picture of the baby that maybe we might ask for another imaging modality, but it is readily available.
That's great. So, but sometimes you tend to operate, if you don't mind me asking, on symptoms and physical exam alone.
No, we never do. We really never do. Ultrasound is, I would say, it's readily available. If the ultrasound does, they are not convinced it's pyloric stenosis, but the clinical picture still is, then we'll probably ask for a contrast study like an upper GI so that we can just.
I gotcha. That's actually fairly common practice to what we do. Nate, I don't mean to distract you, but it's just great to compare management approaches.
No, it's great. Thanks for the question. Maybe at this point, anybody else have any other questions right now of things that we've talked about? I can take a quick break and I know we have some time at the end for questions, but before we get too far along.
And if so, feel free to put it in the chat or unmute. Or if not, we also have some dedicated time at the end too.
Okay. Just distal bowel gas, or make meconium. So again, here's kind of our differential of things that we're going to do. And usually we're going to do an enema first. I like to break this down in a pattern. I'd like to simplify it. Okay. So when I'm teaching my residents about how to work this up, I say you basically need to know these 4 patterns. And if you know these 4 patterns, you kind of know what they go with. It makes things a lot easier for you. Now, I realize this is oversimplified. There are some complexities to it, but I feel like this is a nice kind of easy approach to kind of remember things. So we're going to go through each one of these with cases, and then we'll do a review here at the end of this part. So here's that same patient, failure to pass meconium. Here's kind of a oblique frontal view where we're injecting contrast through the rectum. You can see there's contrast, but there's also kind of this linear filling defect. You can see kind of coming up like this. And here we've turned the patient more on their back, so they're more in a frontal position. And notice the rectum distended well. So we have kind of a normal rectosigmoid ratio, if you will, and we'll talk more about that with Hirschsprung's, but this looks normal, but the caliber of this left colon is rather small until you get up to the splenic flexure, in which you see it distends a little bit more. So kind of that with these linear filling defects should kind of lead you to, you know, this pattern right here where you see kind of a small left colon with filling defects. And this usually goes with functional immaturity of the left colon or meconium plug. It actually has lots of names. You may know it by one of those. So they often present with failure to pass meconium, abdominal distension. And when we do enemas, we often see that the left colon is kind of smaller in caliber and we see lots of filling defects. And the enema is often therapeutic. So even after we do this, they tend to expel those meconium plugs and it tends to open them up and they start to stool after that. We do see an increased incidence in this if the mother was diabetic or given magnesium sulfate during pregnancy. So the nice part is, especially for pediatric radiologists, is it's very satisfying when you do these and they expel all these meconium plugs. In fact, as pediatric radiologists, just for fun, sometimes we have a competition of whose meconium plug was bigger as we get these to come out. So, all right. So here's another case. We're kind of working through this differential of lower tract obstruction. You can see there's dilated air-filled bowel loops, not a lot of bowel gas down here in the pelvis. When we do an enema, here's a lateral view. So you can see here's kind of the lower part of the rectum, and then there's this area of narrowing. And there's even kind of this sawtooth appearance of the bowel of the rectum. And then you can see the sigmoid is much more dilated than this part of the rectum. So this goes best with this pattern, which is kind of a caliber change. And this fits with Hirschsprung disease. So this is caused by absence of ganglion cells. And it usually extends in a retrograde fashion from the anus going backwards. So you don't get Hirschsprung's disease just isolated to the transverse colon or someplace else. It always starts here at the anus and goes retrograde. We see a rectosigmoid ratio less than 1. So the rectum normally distends more than the sigmoid. But in Hirschsprung's, we usually see that the rectum is not able to distend as much as the bowel proximal to it. And the rectal sigmoid area is the most affected, 70 to 80%. However, we do enemas to kind of see if there are signs of Hirschsprung disease, to try and localize it, to try and show surgeons, you know, if they do have Hirschsprung's, how far up is there that absence of ganglion cells. But an enema does not exclude it, right? The diagnosis really is made by rectal wall biopsy to see if there are those ganglion cells. So even if we have an enema that doesn't necessarily show signs of it, if you still suspect it, this is really the gold standard for diagnosis. Okay, and then another case of failure to pass meconium. We move straight to the enema. You can see we put contrast in the colon, and this colon is very small all throughout its course, all the way over here to the right side. And here we're refluxing contrast into some distal small bowel loops, and there's lots of little filling defects in here. So this pattern fits with a diffuse microcolon, where the whole colon is very small. Okay, and this particular case was a case of meconium ileus. but there is a differential for a diffuse microcolon, which we'll cover. But meconium ileus, this is often associated with cystic fibrosis. So they get this inspissated secretions or meconium that come and kind of plug up the distal ileum and the ileocecal valve and make it so meconium can't move into the colon. So that's why their colon is very small. It hasn't really been used at birth. So when we suspect this, we often will test children for cystic fibrosis using a skin sweat test. Here's just a graphical form of kind of all those little meconium plugs kind of plugging up the distal ileum and not letting stuff move into the colon. Here's a companion case. This is that case I showed you earlier of the jejunal atresia, where again, you have a diffuse microcolon. It's very small in caliber all throughout. So the differential diagnosis, if you have a diffuse microcolon on enema, is an upstream atresia, either jejunal or ileal. Meconium ileus. There are some more rare causes like total colonic Hirschsprungs. That's where there's absence of ganglion cells along the entire course of the colon. That's pretty rare. Or there's this rare entity called megacystis microcolon intestinal hypoperistalsis syndrome. Try saying that 3 times fast. It's not easy, but this is more rare. I kind of think of this as almost a smooth muscle disorder where their colon can't relax, but they also have problems with their bladder and their ureters, which kind of helps you cue into that. Okay, so here's another case. So we've got a few dilated bowel loops. And just a word of caution, it does look like these may be haustral markings of the colon. But in neonates, it is really hard to tell small bowel from colon and often don't have haustral markings until they get older. So you don't want to just assume this is colon, especially if there's no other bowel loops that are dilated. How would gas get to the colon but not be anywhere else? So in this case, we did an enema. You can see they have a really small colon, caliber colon, and then it just kind of stopped right here and wouldn't go any further. This fits more kind of with this last pattern. This kind of the short microcolon pattern. And this was a case of colonic atresia, where contrast just came here and the rest of the colon was kind of atretic. It's less common than small bowel atresias, but it does account for a decent percentage of them, and usually affects proximal to the splenic flexure. So usually if there is an atresia, it's going to be kind of on the right side of the colon or the transverse colon. It doesn't usually affect the left side. So now we're going to play a matching game and see if you can fit these things down here at the bottom to which pattern they go with. So if we said meconium ileus, what pattern of enema would we expect to see that with? So hopefully you're all saying, well, the diffuse microcolon, right? Because the inspissated meconium doesn't allow it to go into the colon. Functional immaturity of the left colon or meconium plug. That's the one where we see kind of a small left colon with filling defects. Okay. Classic Hirschsprungs is usually a caliber change at the rectal sigmoid of this pattern. An upstream small bowel atresia. Usually we see a diffuse microcolon. Diabetic mothers associated with small left colon. Total colonic Hirschsprungs is going to be the diffuse microcolon. This megacystis one is also going to be diffuse microcolon, and then colonic atresia is the short microcolon. So you can kind of categorize each of those. So really, those patterns kind of help you put it in those patterns, put them in those categories and help you make those associations. Okay, just one other brief topic to cover on neonates is here you can see a case of anal atresia. And oftentimes, we want to know what is the distance between the anus and the atretic segment of the colon. And so sometimes on radiographs, you can do kind of this backside up in the air where you can see this one has sacral regression, but here's the distal bowel loop that you can see, and then here's the marker on the skin. So you can kind of measure approximately how far this distance is for the repair. You can also see here on ultrasound where you can see this is the fluid distended rectum, kind of measuring to the skin to try and estimate that distance to help with surgical planning for repair. Okay, we're going to shift gears a little bit and cover the older children, and this is going to go a little bit faster, and then we'll just have some time for questions here at the end. So again, here's just a table for your reference of different causes of bowel obstructions in a little bit older children. There's congenital, infectious, inflammatory, iatrogenic, and kind of other causes. There's a differential. This is kind of a mnemonic to help you remember causes of bowel obstruction in older children. And it's AIM or AIM times 2. So adhesions, appendicitis, ileocolic intussusception, inguinal hernia, malrotation with midgut volvulus, and Meckel's diverticulum. So again, here's just kind of an algorithmic approach to do this. We'll just break it down. So abdominal radiograph's always a great place to start. If you suspect they have an upper tract obstruction, then you may do fluoroscopic upper GI, just as we did in the neonate, where we want to make sure we're not missing midgut volvulus. If there's a lower tract obstruction, generally in older kids, we may start with an ultrasound, or if CT is available or needed, then you could maybe do that. Okay, so here's a case. We have a 2-year-old presented with crampy abdominal pain and blood in their stools. We get an abdominal x-ray. This is kind of what we see. This is that case I showed you earlier with stacked dilated bowel loops. What is the next best step? Well, this is a little tough depending on what you have available, but it looks like they have a bowel obstruction. So I guess if it's a 2-year-old, you could do an enema to see if that was available. So that is an option. If you have ultrasound available, that would probably be the next best step if it's available, because most of those things that were on that AIM differential we can look at with ultrasound. So in this particular case, we saw the soft tissue density here. We needed to work that up. And this was an ileocolic intussusception. Again, that's kind of where we get that telescoping of the small bowel into the colon. It kind of accordions and causes an obstruction. Most of them occur in the right colon, about 81%. And of course, the incidence decreases as we go distally in the colon. Most of the time, we don't understand the etiology. It's idiopathic. We think maybe from the lymph tissue that's in the distal ileum that can act as a lead point when kids get sick. But about up to 10% have a pathologic lead point. So a Meckel's diverticulum, duplication cyst, or lymphoma, usually kind of in that order of frequency. And if you have an older child that's 3 or 4 or older, you should think they probably have a pathologic lead point that needs to be worked up. So this is the most common cause of small bowel obstruction in children. At least here in the States, it occurs more common in the winter and spring months when viruses are more kind of prevalent and kids are getting sick. And the most common age is 3 to 36 months of age. So classic presentation is kind of intermittent crampy abdominal pain and current jelly stools, a little bit of blood in the stool. And then we try and reduce this with air enema here in the States. So this is a picture from a fluoroscopic air enema where we've pumped air in, and you can see this shadow right here. That's the intussusception. It usually gets hung up right at the ileocolic or ileocecal valve. And let's see if I can lay this for you. See, okay, so here we're pumping air in. We're kind of pushing. There's the ileocolic intussusception, that shadow right here. We're going to try and push it back and reduce it with air pressure to try and keep them from going to surgery. Again, here's that shadow. And all of a sudden here in just a minute, you'll see reflux of air into small bowel loops as this kind of shadow starts to disappear. And see the reflux of air. So it's been reduced. Obviously, we try our best to do that with air pressure. And if it doesn't reduce, then they need to go to surgery for reduction. But this usually has a pretty good success rate. I think in the literature, it's quoted as 80%. I think in my career, I think it's closer to 80 to 90%. So just keep in mind, abdominal radiographs are about 45% sensitive, so not sensitive at all. You may be able to see this crescent sign where you get this kind of rounded thing with this kind of curvilinear lucency with the fat interdigitated between soft tissue, small bowel. But again, it's not sensitive. You see signs of a bowel obstruction, but it would need to work up what is the underlying cause. If you do have access to ultrasound, it's very accurate. So you can see the sensitivity and specificity is very high. And we're basically looking for kind of this round target sign of an intussusception or a pseudo kidney sign if you see it in the longitudinal view. kind of these alternating dark and light lines. This is a question that comes up a lot if you use ultrasound, is how do you tell an ileocolic intussusception, which needs, a pneumatic reduction or surgery, from a small bowel intussusception, which is usually incidental. So if you measure the diameter and it's greater than 2.5 centimeters, it should be ileocolic. Now, if it's less than 2 centimeters, it's usually a small bowel intussusception, just a small bowel. I realize there's some gray area between 2 and 2.5, but these are kind of the cutoffs that I like to use. And if you notice, ileocolics will have more fat in the middle, actually be more fat than the diameter or the thickness of the wall, I should say, whereas a small bowel usually has less fat in it. So just in review, where are the majority of ileocolic intussusceptions found in the abdomen?
People are thinking I also was going to highlight, looks like we've got a question in the chat.
Right.
Great. Thank you, Stella, for the question. So how many attempts do you try for the pneumatic reduction before you call it and go operative? So the way that we teach our residents and the way that our board exams are set up is it's 3 tries. Now, what you define as a try is kind of up to the clinician. In our practice, if we try to reduce it, meaning we bring the child over, we're using air pressure, and we usually can get it reduced to the ileocecal valve, and it gets stuck there. And it's just not going. We'll often send them back to their room or to the ER, give them a break, kind of let things calm down, and then bring them back in an hour, try again. So usually in our practice, we'll try around 3 times to see if we can reduce it. And after that, usually our surgeons will take them to surgery and reduce it. But we do all that we can to try and prevent them from having an operation if possible. Great question about pressure. So usually 120 millimeters of mercury. If you're using, we have like a little sphygmomanometer hand pump is what we use that has a pressure gauge on it. So I just remember kind of systolic blood pressure. You don't want to go over that. If the child's crying and you have good air pressure, you might see that spike higher. But while you're pumping, you don't want to go above 120. Okay, great questions. All right, I'll move on. So right colon is where you're going to see most of these. And then what ultrasound feature can help you distinguish an ileocolic intussusception from a small bowel intussusception? And hopefully you remember this. Just for time's sake, I'm going to move on, but the diameter greater than 2.5 should be an ileocolic intussusception. Here's a 12-year-old. We're going to move on just for time's sake so we can get through the rest of these cases. Presents with abdominal pain and emesis for 3 days. The ultrasound was done, but it was kind of equivocal for acute findings. So what's the most likely diagnosis? So again, this is a small bowel obstruction due to acute appendicitis. Here is kind of the dilated appendix. You can see a little stone or appendiculate here. You can see big dilated bowel loops here on the CT. So most common atraumatic surgical indication for children, and it can cause a small bowel obstruction secondary to inflammation. And you usually see that when it's complicated or if it's perforated. Generally here in the United States, we'll use ultrasound on pediatric patients as kind of the first modality to look for this. But sometimes if it's complicated, if it's perforated, if there's a bunch of dilated bowel in the way, they may not be able to see it, in which case our next step is to do CT. Going to go kind of quickly through these last cases. So this case, child presents to the ER with vomiting. You can see they have kind of a dilated bowel loops kind of all throughout. What's the next best test? So you might just say, well, yeah, they kind of look obstructed, but they have a lot of stool. I'm not sure that I see a whole lot else, but if you look really carefully, there's a bowel loop kind of sneaking down here into the right groin, right? So this might be the cause of the obstruction, which it is. So, if you needed something else besides this to confirm, a groin ultrasound might be a great choice in a young child. You can see here's a groin ultrasound where you see some bowel kind of herniating down. This is the testicle, a little hydrocele in the scrotum. So congenital inguinal hernia can affect, a small percentage of children, but they can present with a small bowel obstruction. If you're lucky enough to see it on X-ray, you may not need anything else, but ultrasound can help, confirm that diagnosis. Okay, so now we're going to move over to the last few cases that involve maybe some more cross-sectional imaging. This is a 2-year-old male presents with acute abdominal pain, and you can see there's a little bit of swirling of the mesentery over here on this coronal contrast enhanced image. There's this fluid-filled structure with this little beak. And they also got ultrasound, and we saw this is the bladder. And then there's this kind of fluid-filled structure sitting on top of the bladder with a bunch of debris. This is a scan from a Meckel's scan. So you can see the technetium here has some uptake down here in the distal small bowel. So this was a torsed Meckel's diverticulum. So where it's kind of twisted around itself, it's all inflamed, and that little beak is the twisting, and that swirling of the mesentery was where it had kind of twisted around in the right lower quadrant. So this can also be a cause of bowel obstruction. It can be very difficult to diagnose. Usually you won't see much on plain film other than maybe signs of obstruction. Even ultrasound and CT and MR can be difficult to detect, and sometimes may just need surgical intervention. If you have access to nuclear medicine scans, you can confirm, the presence of gastric mucosa. It can be confirmatory for Meckel's diverticulum, but these can be challenging cases. Here's a case of inflammatory bowel disease. This is in an older child, obviously, but this can also be a cause of obstruction where they get inflammation. They can get stricturing. This is the terminal ileum, where you can see the bowel wall thicken and it's enhanced. And an additional case on MR where you just see this really, really thickened terminal ileum, upstream bowel dilation. CT and MR are really good at looking at this, but there's more and more use of ultrasound to look for these signs of inflammatory bowel disease. I guess if you saw this in the acute setting, this could also be infectious. If you saw bowel wall thickening of the terminal ileum, I think Yersinia can cause this, and TB. So it can be infectious, inflammatory. You probably need a full workup to diagnose inflammatory bowel disease versus an infection. Okay, this is a little bit older patient, so a 20-year-old with cystic fibrosis. This is something we don't see a whole lot, but there are signs of a bowel obstruction, air fluid levels, dilated bowel loops. But then you can see kind of all this kind of almost looks like stool in the distal small bowel. And then you can see this is where their pancreas should live, but it's all fat. So we see that with cystic fibrosis where you get fatty atrophy of the pancreas. And this is a case of distal intestinal obstruction syndrome. It's kind of a more rare diagnosis, but it's almost similar to meconium ileus in an infant, where you get this inspissated stool that backs up in the distal small bowel and causes an obstruction. Okay, so last but not least, we're going to talk about these things that you can kind of see on radiographs. So adjusted foreign bodies. So this child had swallowed a coin and multiple small magnets. And the magnets are problematic if you get more than one, because if they're in opposite, if they're in different bowel loops and they kind of get stuck together, it can cause necrosis of those bowel loops and perforation. So this is concerning when you have multiple. Here's a child who swallowed a button. Here's one who swallowed a button battery. You can see that lucency around there, and it usually has a beveled edge. And this is an emergency because this causes burns in the esophagus and can cause perforation. It can cause fistulas, all sorts of problems. So if you ever see this on a radiograph, this needs to be taken out as soon as possible. Just a few other examples of dull and sharp objects that patients have ingested or put into their rectum. Here's just a more interesting case of a trichobezoar. So this is a child who was eating hair, and this is a bunch of hair in their stomach that was causing intermittent gastric outlet obstruction. This is what it looked like after they took it out. So this is just like a big wad of hair. And then here's one other case where you can see, again, signs of bowel obstruction, stacked loops of bowel. But then there's all this stuff in the small bowel. And here's them taking this long piece of hair out of the small bowel that had hung down from the stomach. So kind of gross. Sorry if I spoiled your breakfast by watching that, but So ingested foreign bodies, they're pretty common. Thankfully, only 1% or so need surgery or interventions, but the things you should be aware of, button batteries, magnets, and Bezors often need intervention. So again, here's just that table of high and low obstructions in neonates for review. Here is the algorithm that we talked about, and I'll try and make these available for you. And then again, the causes of bowel obstruction in older children, so your differential changes a little bit. That mnemonic to help you remember common causes of bowel obstruction in older children, that AIM. And then that algorithm that we talked about. These are some additional references that I'm happy to send out for some light reading. And thanks so much for having me, and I'm happy to take any questions.
Fantastic. Thank you so much. That was an excellent, excellent talk. I was going to say, I can go ahead and stop the recording now so people can feel free to either unmute themselves or throw questions in the chat and have a little bit of a Q&A at the end.